Welcome to this evening's Facebook Live. My name is Alec O'Dare. I'm the Managing Director of Wound Care People and the Journal of General Practice Nursing. Welcome back for all of those who have joined us before, and a huge welcome and thank you for joining us, for anybody that's joining us for the first time this evening. So this evening's session is being delivered remotely. As you can see, we're in our houses or hotel rooms. So please do bear with us if we have any technical issues. We've done lots of rehearsals and we will be back. The session this evening is called Making Shared Management of Wounds Part of Everyday Life. And we have one of our regular speakers with us this evening. We've got Alison Schofield, who's the Tissue Viability Lead for and Clinical Nurse Specialist for North Lincolnshire and Goole NHS Foundation Trust. And we have a special guest joining us this evening with Alison, which is Lynn Ramsey, who's the Nurse Manager and Diabetes Specialist Nurse in Reedsmoor Medical Centre in East Cheshire. Ladies, are you there? How are you both?
Fine, thank you.
Yeah, good, thanks. Hi, everybody.
Hi.
Excellent. I'm very much looking forward to this evening's session. I'd just like to thank Hartman for supporting this evening's event and for sponsoring the session. As always, certificates will be available via a link at the end of the presentation. Please send us any questions that you may have just by typing those into the chat box to the right-hand side of your screen, and we'll get through as many of them as possible during the live Q&A. Don't forget, if we don't get through to your question this evening live, what we will do is we will come back and answer that and put it as part of a document alongside the edited version of the video and the slides via our website. So without further ado, I'm going to hand over to Alison to start. And ladies, good luck, and I look forward to chatting with you after the presentation during the live Q&A.
Okay, thank you.
Thanks, Alec. Right, hello everybody, good evening, and I hope you're all okay on this autumnal night. And so we're going to be talking about shared care within practice, and more important has it been. So the learning objectives we're going to be looking at this evening are: what is shared care in clinical practice and why is that so important for all of us involved? So what are the benefits to both the patient and, of course, us as a healthcare professional? What challenges do we face in wound care post-COVID-19, and why will a shared care approach be pivotal to a successful service moving forward? We're going to learn how the role of the general practice nurse can support effective shared care in wound management. And we're going to look at some tools that are available to help us with an effective shared care solution for more patients in the future. So first of all, we need to look at what exactly is shared care. So that means it's the ability for the healthcare professional and the patient to embark on a journey in the management of a minor illness, healthcare need, or chronic disease. And some of this has been done for many years, is already done already. So we're going to learn how we can draw on that to use within wound care practice. So this approach can be taken in different forms. A patient may take on 100% of their management. So some of us will do that already, because it might be that we have to be on a diet program, exercise program for our own health. So we do that 100% ourselves. And it can go to the other extreme, where 100% of care from healthcare professionals is provided for the patient. So, if a patient is in intensive care, for example, they are relying on us for all aspects of care. And then everything in between that is described as a shared care, or there are degrees of self-management shared care. So where possible, we want to encourage patients to take on that, because we want them to be more empowered and take an active role. So from the political agenda, the government agenda, NHS England and NHS Improvement have already got some things in place. We've got documentation such as the NHS long-term plan. And if you look that up, it's got lots of information around health coaching. And this is to encourage patients to take a more active role in their own health and well-being. So the long-term plan aims to empower patients to take that ownership of their overall health and well-being, so particularly in chronic disease management. Now, as we said before, this may encompass all sorts of things like exercise, diet, but all these things, it's a real holistic assessment and pathway, and wound care obviously becomes within that too. So wound care, isn't an exception to this, and we can engage with our patients, developing really good partnerships and sharing the care of their wounds. But most importantly, we're giving them the tools as well to optimize their ability to heal. And remember, it's not always about that ultimate goal for patients of healing the wound. Sometimes it's symptom management, management of odor, of exudate, and pain relief as well. So that supported self-management, we're not saying to patients, off you go, there's your plan and, get on with it yourselves. It's about shared care between those healthcare professionals. So it's one of the 6 evidence-based competencies of personalised care to which the NHS has already committed to. So principles of self-care you can find on the Self-Care Forum website, and that includes involving patients in decision making. So, we always say put the patient at the heart of our care planning. Well, we need to involve them in all aspects of this, from the assessment to the treatment plans and then the ongoing management plan. So we're developing full care plans together. And remember, patients are very individualised in their particular plans of care of what they need. So set goals for them. Remember, I said it's not always healing. Sometimes it's about symptom management. Let's not just go from 0 to healing. Let's look at everything in between. If we set smaller goals, then we're likely to get much more commitment, and we can get that motivation from patients as well. So with the shared care, we're arranging for them to be able to give them the ability to be involved in their own care, but also arranging follow-ups for to continue and monitor the progress. So we're also helping the patients then to understand what to look out for and how to get help if they need. We need to make sure they've got all the information about infection, if anything's going wrong, but also when things are going right as well. And then, give them all the appropriate contacts. And also it could be that there's, information such as on the National Wound Care Strategy website, there's lots of literature and videos that patients can access to be able to get, some more information. So we're motivating them with a really, really good structure and support system. And within that, promoting that all healthy lifestyle holistic care. Education is so important, and I think often we think patients not necessarily understanding about their disease process. And I know when we talk to Lynn later that, within practice nursing, that's been done for years around diabetes management, asthma management. So why not within wound care? Why can't we educate patients on the cause of wound, how wounds heal, and how to best self-care and shared care to be able to promote and best manage them. So why is it so important, shared care? Well, patients who live with a chronic disease or a wound, which is a chronic disease, we think in terms of venous leg ulcers, for example, they will often experience physical and psychological emotions that can lead to a sense of negative well-being. So people can get very low mood, very depressed, which then has a knock-on effect for sleeping. They might not be eating so well, so then this affects all the bodily symptoms and then can lead to poor wound healing. So as healthcare professionals, the aim is for us to support, manage and improve that well-being. So the benefit of this to the patients, we can see in the table, is gives them much better sense of purpose. They're so actively involved. We've got to change those historic attitudes that we have in nursing of, in wound care particularly, of we will change the dressing. We don't want the patients to touch the dressing. We don't want the carers to change the dressing. Why not? We've got to turn that completely on its head. So the patients are setting their own goals, and then they feel much more of a sense of achievement, achieving those goals. And let's remember, small goals one at a time. So they will then have a much better understanding of their conditions and requirements and more likely to comply. They have much more of motivation towards that end goal. There are also financial benefits because remember, it's not always people who are of an older age who get wounds. Many people are of all ages, and people might be working, so they might be losing finance because they're not able to work because of ongoing chronic ulceration or wounds. It may be that they're having to pay out for prescriptions for lots of dressings. So the benefits to us as healthcare professionals means that we've got a much better effective use of our resources, and we're going to look at that in much more detail coming up. The impact on the quality of the treatment we're giving, will be very much improved, and we're going to get much better clinical outcomes because we've got the patients fully on board and engaged. And it's much more cost-effective care to the NHS. And we know that burden of wound care, £5.3 billion and growing. We need to do something about it now before it gets completely out of control. So we need to identify the responsibilities here. So we need to assess, that full holistic assessment with the patient to assess their capability and willingness to perform those dressing changes. And that's in between visits that we may do or clinics that they may attend. So it may be that capabilities include dexterity. It might be just simple wound dressing changes, but it also may include compression garments like wraps and hosiery. We've got much more things readily available to us now to assist patients in supported share care. So we need to identify with the patient the plan of care and how that's going to work. And remember, everybody has an individual plan, and it may be that involves the families of patients, carers. It may be patients in a care home setting. And we can involve those within that too. And when we think of the COVID-19 pandemic, and we're saying post-COVID, but actually we're entering into the second wave right now. We've got a long winter ahead of us, so we really need to learn from the previous lessons, and we need to be embracing this now. So we need to choose the most appropriate dressing selection that the patient can cope with clear objective and desired outcomes for them. So we're going to educate the patients on red flags. So that might be around signs of wound infection, when there's any changes. Has the wound increased in size? Is there more exudate? And so we've got to encourage them to keep their own records for this. So keeping a diary. It might be that they're taking photographs and that they can share with you on email or some sort of digital platform. So we're going to educate the patient then on how to change that dressing safely, and that will include, clean techniques, washing hands, which we have many resources available to us about that at the moment, so that they can safely and confidently do that without worry. So we want the patient to understand and feel really confident to be able to perform these tasks with them, or they may feel, for them to feel confident with a family member or a carer doing that as well. So it's not just the qualified nurse every time having to do this. So we want them to understand and know when to report a change in that wound progression. It might be a negative, like we've said, but it also might be positive. There's nothing better than they can, if they can measure the wound, or they can take photographs, or we need to educate them about the signs and symptoms of what a wound looks like. And if they can see that it's healing, they're going to feel much more encouraged and motivated to be involved in their own care. So they will need to agree. So we're kind of engaging in that care plan like a type of contract of when they will attend a clinic appointment, or when they are available for home visits to be carried out by the healthcare professionals that have been scheduled for them. And we also need to give them that reassurance that, that's not set in stone. If they then feel uncomfortable or they think, oh, something's not quite right and they need to be seen sooner, then that's absolutely fine, and that we can cater that for them. So we can, titrate things up or down according to their needs. So I just want to mention about within my own service, and I'm a tissue viability nurse. I'm in contact with tissue viability nurses across the UK, and how the impact of coronavirus has had within our services, and how that's then impacted on shared care. And I think this is something we've been talking about for a long time, is around shared care, but it's kind of been thrust upon us because of COVID-19. So in my own area of working, we have a chronic wound clinic, which is predominantly legal service, and that was closed down for a period. So people were having to be seen at home. So the staff there identified quickly patients who were able, suitable, and they did, the appropriate assessments with them. Were they willing to be able to self-care at home? And a number were, with types of compression systems and dressings, and some, were quite happy to go along, and they'd just ring up when they had a problem, or, they'd be contacted and they were, quite happy and everything was going on great. One or two, we had to change the program and they had to be seen a little bit more regularly. So, it is very, very individualized. But looking at that long-term NHS long-term plan, we've carried on with that, and even within district nursing and housebound patients as well, we've been able to get some element of shared care within that too. So we're not having to visit as often, which has suited patients because they've been a bit fearful of people going in because of coronavirus. Within our care homes, it's been the same situation, and within primary care, we know patients have been reluctant to go into practices, so they've been caring at home for themselves. And I know Lynn's going to touch on that a little bit when we speak to her in a moment. So, hello, Lynn.
Hello.
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 Thank you so much for coming on to speak to us this evening. And I know that you have a role, and you've worked in nursing and within primary care for a long period, and you have a role as a practice nurse manager. So I know we had a bit of a chat earlier, and you were telling me that within a lot of and practice nurses who are watching will identify that a lot of their role is commissioned to be chronic disease management in asthma care, diabetes, and other things around that, which you do. But wound care is becoming much more prominent in your services, and that you are delivering more and more of that, and probably more so in the future. So how has that impacted on services that you've been involved with?
I mean, I've seen it change over the years dramatically. I mean, 17 years ago, the wounds we were looking at 17 years ago are not the wounds we're now looking at in practice nursing. They're really, really complex. Things from wounds on feet, all the way through to people coming in with post-op wounds. And we're seeing patients now that we would never have seen in a GP practice. And like you say, because we work under the framework of QOF and we are very well trained with chronic disease management, wound care is a sort of by the by, it's something that practice nurses do. And I think those are the challenges, because the wounds are now much harder, and it isn't just see one, do one. We have to have that sort of shared care amongst ourselves with professionals, as well as the patient. And it has the challenges, even from the cost of getting the dressings into the practice, people not wanting to pay for their dressings when they need dressings on prescription. So in which case we carry on paying for the dressings, and there's a stress on the budget of what we're paying for dressings. And it just goes on in a circle, that it's getting more and more complex. And our challenges also in practice are huge with the flus and with the COVID, although that has had lots of positives, I think, with the wound situation, which we can talk about.
And I know
So
you
that's the situation. Sorry?
Sorry, I was saying, I know you told me yesterday you had to perform 500 flu vaccinations, which is a massive amount of your time, and this time of year. So like say you're kind of delivering more and more wound care, but how, are you actually allocated, do you think, enough time in practice to do that?
There isn't enough time to do everything. We're very stretched, and I'm sure all the practice nurses out there would agree with me that it's a real sort of, you've got all the balls in the air. We're still doing the chronic disease management. We've still got the flu. The flu will continue this year, so it will take us out completely from September right the way through to February at this rate. So all those treatment room appointments that we had, we've gone down to an absolute minimum. So yeah, the challenges are huge, even more so right now.
And so, wound care within practice nursing, like I say, it's those skills within that, and learning new skills must be quite a challenge. And what sort of support and education do you have available for that?
Again, this is my experience of the last 6 years in the 2 roles that I've had. Wound care, we don't have an awful lot of training. I mean, it's very easy to get training on diabetes. Every week there's webinars going on about diabetes, about asthma, usually driven by the pharma companies, and they're there to give us our support and our training. I do lunch and learns, and I try to get guest speakers in to do those, but it's really hard to find somebody to come in. And then of course you're only seeing one product, so people don't just go off to do their wound diploma like you do with diabetes. So that level of knowledge that we now need in practice, we haven't got the same amount of training available to deal what we have to deal with. We get in the tissue viability when we can, and that hour is very precious to the nurse that stood there with her, because you learn lots.
So
yeah, go on.
would you agree that I mean, I know the National Wound Care Strategy and the lower limb pathway that's been worked on, and will be, that those things will be coming out to our CCG and primary care networks very soon. That they're kind of very keen on that MDT approach. So all of us actively working together within that is shared care with the patient. So we would all be supporting you, because sometimes we were talking about, sometimes it's difficult with some patients that we feel that they can't perform particular things, but maybe it's something that I know of, a particular thing that and we can share that and work that care plan together with the patient. Do you think that that's important?
I think it's really important. I think we really need to have that knowledge and be able to work together. So there's nothing greater than when the tissue viability nurse comes in, we have a joint plan, we speak. If it doesn't change in 2 weeks, we'll be back to you. And we've then got that plan to go forward with the patient, and the patient's involved in that an awful lot. But that doesn't happen with every patient, obviously, because it couldn't possibly. And I think there's very few tissue viability nurses out there to help us, and very many wounds. And but I do see with primary care networks that things are changing. In my previous practice, things were changing, but quite often you've got the patients that are down the road, and it's where they have to go for that extra care. It's also hard.
Absolutely. And I mean, and obviously tissue viability is my, that's what I do, that's my speciality, but I also feel that we're kind of embarking on the shared care journey at the moment in wound care, but in primary care, in practice, and so you've been doing this for years with some of your chronic disease management and successfully achieving that. What can we adopt and learn from you in those processes that you've already got in place?
I think for me, shared care with the patient would work better if shared care with the professionals was better. So I think if those bridges would get more with, because we're all very stressed and we're all working really hard, but those bridges between tissue viability, district nurses, if we could somehow talk better about individual patients, and then we can involve patients in that, but quite often we don't talk. So there's the pre training that hasn't been done, and the wounds are almost set up a corner that we fit them in, we do the wounds, but we don't ever manage, I don't think, to do that shared care. Whereas in diabetes, I won't succeed with a diabetic patient if they're not 100% on board and I'm going 100% where they want to go. But with wounds, we don't put the same emphasis.
No. Do you use, like, in with your diabetic patients, so you use like documentation and sort of care planning? Do you use those sorts of tools?
Yeah, and goals. You set the goals of where they want their control to be, not where we need it to be. It's where they want their control to be, and just small goals to get them there. And when they're motivated and they're happy to work with you, then you will always achieve with diabetes. And it's the same that we want to try and do with wounds, but we haven't always got that expertise or that time.
Okay. And I know you were telling me before you've done some auditing in
Yeah.
practice, which I'm really interested in, because that, I think that's valuable information.
Mhm.
So, you know, what sort of patients is it predominantly that you have in primary care? I know you said the changes are becoming much more chronic and complex.
Yes.
And are there patients currently who are share caring, you know, with yourselves?
Yeah, they are. Because I'm into a new practice, I wanted to audit all the wounds to see where we were up to and what we were doing and how we were managing the wounds. Just because I wanted to look at time management, appointments, skill mix, and the sort of people we were getting through the door. So I actually did an audit with a colleague at work from the 1st of July till the end of September, and it was 123 patients over that time. And when I actually broke it down, there was an awful lot of post-ops, an awful lot of head injuries, which I was surprised with, a number of burns. The majority of people that were on that audit for the longest time were obviously the leg ulcers, although we didn't have a huge amount of leg ulcers. So perhaps in the area I've now come into, we're managing leg ulcers much better. But the amount of people that were coming for more appointments, we had patients on there for 156 weeks, and that was the highest. And then they came down to 65, 54, 39, 32, loads of referrals to tissue viability and district nurses. These people were coming to us 3 times weekly. The ones that were here for like 6 weeks, 8 weeks, they seem to be the ones that you've got the better shared care with. But the ones that are on the longest are the ones that you really struggle with the most, because these are people that can't do their own dressings, can't get themselves to the practice quite often, and they're the ones that are on for 3 times weekly. So to involve carers or it's a really difficult one, because these are the ones that keep coming back. These are the ones that are not healing. So to get shared care with these, they're reliant on us.
Yeah.
And that's what the that's what the audit showed to me. And these are the biggest DNA rates.
Yeah, yeah. And that's where our whole shared care between us all, including the patient, will kind of,
Absolutely. Yeah.
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 Thank you so much, Lynn. If anybody has any questions for Lynn at the end, you know, you'll be able to ask questions to us. I think you'll agree. It's fascinating, you know, and it's you know, a really important area of wound care within primary care that we really need to do some focus on. So, you know, post COVID-19, well, we're still, you know, we're still there, aren't we? We're kind of heading, you know, right into the second wave at the moment. So the challenges that we still have, and, you know, what can we do about this? Well, you know, we have a sequin on lower limb assessment, which has been which was postponed because of the challenges we've had. And we don't know when. I know the lower limb strategy have said it could be 2021, and it could even be 2022, depending on the outfall of COVID, of when that will be done. But that will also give us a lot of audit around leg ulcer prevalence and you know, our situation of that. So we have the challenge of management of patients who have deteriorated, because, you know, Lynn was saying there's patients who, you know, have been, they've been for weeks and weeks and weeks. Lots of patients we've been saying who are frightened to come out into practices. You know, there's a lot of lockdowns coming again, so we will see that, where patients are just trying to care for what they may deem as minor injury wounds at the time, but then, you know, they can lead on to, if they've got venous disease, onto ulceration. You know, there could be malignancy, wounds, you know, many different things. There's an increase in inpatient referrals, and we know that then there's a delay on inpatient services that for patients to be seen. And in our chronic wound clinics, if we, you know, we get in, if they're closing again, then we're getting a backlog of patients who are needing the all-important specialist initial assessment to get the right pathway. We've seen an increase in pressure ulceration in the post-COVID-19 patients, and of course coronavirus itself has particular skin manifestations. We're just learning, you know, about all these types of things too. So you know, then the long-term effects of what we call long COVID, what that might have on chronic disease management, and you know, lung conditions, oxygen reductions, and so there's many challenges that we're having to face. So let's just look at a case study of a successful shared care approach. So this looks at a 73-year-old man who presented with a diabetic foot ulcer. So he had an ulcer to the outside of his foot. He has type 2 diabetes himself. This wound had been present approximately about 9 months, so quite a long period of time. Now, he will have been seen within, you know, the referral process of diabetic foot clinic, but then some shared care systems came from that. So 80% of the wound bed was granulation tissue, which is good, but the remaining 20% of the wound, of the area which is slough, so devitalized tissue. So the wound itself was, you know, it had moderate amount of exudate, so, you know, we could manage that quite well. The wound edge and the peri-wound skin had some maceration, so, you know, some of that exudate was causing that, which then can make it more prone to bacteria and infection. So the wound was being treated with a superabsorbent polymer pad. So that was addressing exudate management and also some infection control with that too, infection prevention. So 2 days after that initial assessment, the patient was deemed as being able to self-care for the remainder of the assessment period. So they returned to the clinic every 5 days. So they've gone from 2-3 days a week to once every 5 days. So on day 7, the wound had actually reduced in size by 20%. And so the granulation tissue as well had increased to 90%. And there's less maceration. We've got more epithelial cells. So the wound is starting to heal. So the patient self-caring for the wound carried on for a further 5 days. And he found it really easy to, you know, apply the dressings himself. So when we look at obviously the resources with that, you know, I mean, we've got, you know, we're reducing the number of clinic days, and this gives us an example here on this table of how freeing up resources can benefit. So we know that the financial cost of the NHS is enormous, and the biggest cost in what we do is in our time, is in nursing time, whether that's practice nursing or district nursing. So this example looks at district nursing cost per hour, which is £112. So if an average cost per visit from the district nurse is £62. So if you look at a list of 10 patients a day, which is, you know, it's not uncommon. Often there are a lot more. There might not all be wound care, but a lot of this, you know, type of community nursing is wound care. And so 10 patients would add up to £620. So we're looking at 50 patients on average across that whole week, then it's, you know, we're over £3,000 cost for that particular type of wound care. So, you know, average visits, you know, say 2.5 visits a week, three visits, £155. So we could have a potential saving there by, you know, taking some of that visit away and sharing that care, you know, of that nurse visit of £62. So when we're looking at using our resources differently, and you're thinking of, when you're running clinics, or, you've got your list of 10 plus, you're a district nurse leader and you're looking at all the number of visits that you've got, how are we going to free up some of our time? And shared care can do that really, really well. So, the more patients that we get involved in shared care, the more time we've got for resources for doing other things. And then that has a knock-on effect, obviously, from a financial point of view. So if we had 15 patients in a shared care pathway, reducing those visits, we could save them £930 within that working week. So let's look at shared care on how resources were saved in this way. So there was a young adult male with a sarcoma wound, and he needed 3 appointments a week for the management of this at an outpatient clinic. So the average cost for this particular professional was £105 per patient contact. So 5 months of those appointments at 3 visits a week for 22 weeks. So that's a total of 66 appointments. So the financial cost of that to the NHS would be just short of £7,000. So by reducing that patient visit to just coming once a week and being involved in a shared care pathway, so then we can look at that reduction. So 1 visit a week for 22 weeks, 22 appointments. So, the cost now is £2,310. So we've saved 44 appointment slots. So that's for new patients coming through, patients who might be waiting a long time, who need, more input, or, what else can we do with those resources? And then the financial cost there is £4,620 in just that one patient contact, which, is phenomenal, really. So for the patient, importantly, they've improved their self-esteem, improved concordance, they've got improved motivation, better quality of life. And so then wound healing is much more effective with all that for them because of all those aspects. So just thinking about yourself, if you're listening tonight, if you're working in practice nursing and you're running services, if you're a practice manager like Lynn, if you're, working in district, wherever it is, whichever area you're working in, with that resource saving, what would you do with that time? Could you deliver more patient education, more staff education? Like Lynn was saying, can you get more education resources in for the staff so we've got better learning, we've got time to do that, or can we get much more new patient appointments through our system? So I'm really excited to be able to introduce to you the Shared Care at Home project. Now, we've been keeping this kind of under wraps. I've not been able to say anything, but I've been working with Hartman really closely, and we have come up with this acronym and these tools to be able to help you with your patients to support shared care. So HOME stands for holistic, which is the patient shared care. The outline, which is patient shared care action plans. The M is for manage patient-friendly shared care pathways. And the E is for evaluating and educating in patient shared care for the future. So the principles of the home are that we want to be able to provide you with relevant tools to support both yourselves but your patients to develop positive shared care partnership in pathways. Because, we're always talking about this, but, where are the tools? And we don't want to all just kind of start reinventing our own. And so we've done this for you. So we've got things available that you can take away and use in practice. So as I said, HOME is an acronym designed to help support identification, assessment and implementation of partnerships in shared care wound management. So it's a complete guide. It takes a really clear look at the area of a patient's activities of daily living. So, think back to your nurse training days, activities of daily living, and that encompasses all the holistic aspects of care that are important to a patient's daily needs. So we want to maximise the patient's potential to be able to be confident and have that ability to share some of the care which is required for their wounds. So these are the tools that we've got available for you. So we've got holistic assessment, planning and implementation guides. We've got patient postcards. So on there, it explains to them what it is, and then you can write on there, nurse contacts and the contact details for when they need to, who they need to be able to get in touch with, have they got any issues, problems, or just to report good practice. We have also, let me just look back. What else have we got? Patient-friendly care plans. We've got a patient-friendly journal. Now, a journal is so important for the patient to be able to properly record, their thoughts, their feelings, their wound measurements, and anything that is important to them. So there's going to be a new website where you can get all this information for you and your patient and access to all these resources. So it's a structured care educational package, and it's aimed at providing you with the necessary support and tools so you can actively identify, support, and then implement. So it's a real shared care approach with your patients. So just to summarise everything that we've talked about this evening, that shared care is a real positive step for everybody, for us, for our patients. And COVID-19, I know you will all know, it's made us realise that our patients are able to make a much more active role in their wound management. And, we've had a lot of evidence that this has been a real success. And, the benefits to both the NHS, all of us, most importantly to the patients, gives everybody a much more time. The patient doesn't have to be tied to come into the clinic 3 times a week, waiting at home for somebody to come in because, the clinics they normally access is closed, getting the bus because the specialist clinic is such a long way away. Remember about those resources for your services. What would you do with that extra time and that resource? So I'm giving you a call to action, and I want you to book onto the Shared Care at Home educational package so you can learn more about all the tools and resources that we have developed to support you and your organisation. So to get your home pack and start sharing the care, you must contact your local Hartman representatives, and they can give you all the information that you require. So I hope you're going to join us in the journey of home, and then you'll be able to share with us all the great results over this winter period. So I will stop talking now, and I'm going to hand over to Alec, and I hope we've got some good questions from you lovely people that we hopefully Lynn and I can address for you.
Thank you very much, Alison, and thank you, Lynn. That was a really interesting presentation. I think the home initiative is very good. I know that we're going to be putting up lots of links to the resources that you've mentioned today in the next few moments for everybody to get hold of, and also you'll be able to download a lot of this stuff from our website and from the Hartman website. They've developed a special website that Alison actually mentioned just then, which we were hoping would be launched this evening, but it's going to be delayed just ever so slightly. So we'll be in touch with everybody and let you know when that is available. Lynn, I thought you did a wonderful job for your first Facebook Live with us. How are you feeling?
Absolutely fine.
Good. Well, in which case, without further ado, I'm going to get straight onto the questions, because one of the things that has been quite evident this evening is there's lots and lots of nurses who have lots of questions around this sort of shared care idea. So without further ado, we'll go to question number 1, and this is from Linda, and this is: there is still a fear of patients taking photos of wounds. What can we do about this? Alison, I'll ask you this as the tissue viability specialist. So there's still a fear of patients taking wounds. I think that probably means there's still a fear from patients taking wounds, maybe? Taking photos of wounds?
There could be 2 things here. I mean, it could be that the patients are fearful of photographing and seeing their wounds, or, if it's a family member or carer, and that they don't want to look at it. And obviously that, that's their choice. And we're not saying they have to do it. It's just an option that they are able to do it. There also might be, somebody might be talking about a governance issue of taking them, but if they're taking things, a lot of patients do that anyway on their own phones and things, and that's their own, it's their personal wound. And if they take the photographs, if they're sharing them with us, if that's a possibility, you have to check that in your trust. I know I have a secure NHS email, so if patients send them like that, that's absolutely fine. Or it may be just that they keep them in their own phones on a folder to show you when you come for your next visit. So it's very individual. So you have to have those conversations with the patient and look at your own policies within your trust. So it's just an option that some patients like to do that.
Yeah, and I think just looking back at that now, like thinking about it in the context that we've been talking about sort of for the last 45 minutes or something, it's potentially patients who are if you're asking it with shared care, if you're asking them to sort of take photos and report them back and stuff, actually maybe they don't want to take their own pictures of their wounds because either they don't want to see it, or maybe there's an embarrassment issue. They don't want carers and family members to take the picture. I think you just got to sort of normalize the fact that wounds they exist. People live with wounds. I think we all sort of know and hear stories about patients who sort of live with wounds and just don't tell anybody that they've got one. And until people realize the amount of them there exist all over the world, people are always going to hide them, I guess, aren't they?
Yeah, and we have, when we've got, there's lots of case studies been published and things like that where we've all, patients have consented to us using their photographs. So maybe it's that they could look at, see images from those people, can share the case studies of things that are similar to theirs, and so they can identify with that. That's maybe an option.
Yeah. So the next question is from Claire, and I'm going to ask this to the two of you. We'll start with Lynn. Where do you stand on teaching family members to do compression? I was under the impression it was only trained nurses. Can we also teach families? Lynn, do you? Is this something that
No,
you do or advocate?
No, we don't do compression in the practice at the moment. So that would be over to Alison really to answer that.
Yeah. Yeah, I have in my tissue viability lifetime taught family members to do compression. There are, compression bandaging now, we've got two less systems. Some have indicators on them of how much compression to put on. Some, like short stretch systems, you can't over compress it. And we've done that because people go on a holiday and stuff like that. Or I've even seen patients do full lymphedema bandaging themselves because, it's their condition and they've done that. It's not for everybody, of course, but now we're in the luxury of having like compression garments. We've got hosiery kits we use first line, wrap systems. Yeah, absolutely. Get out there, we've got to change, we've got to knock all this on its head, we've got to turn it round and empower people to be able to do it. People inject themselves, they do all sorts of, Linda, yeah, they do all sorts
they do
themselves in their conditions, but we just seem to have this fear over, managing a wound. So individual assessment, of course, but I'm all for it.
Yeah. So question number 3 is from John, and this is prevention is better than cure. Do you think we should be targeting advice earlier to patients to possibly prevent possible future problems?
Yeah.
Lynn, how about?
Obviously, I'm talking very much from a diabetes point of view. I think there's an awful, when somebody's newly diagnosed as diabetes, we have to give out an awful lot of information within the first few consultations, and they're now generally on the telephone. And I think it's very important to stress that, if we haven't got good control with diabetes and we haven't got good activity, good diet as well, because people will go into like starvation mode once they knew they've got diabetes, that it's very, very important that we talk about them checking their limbs, checking their feet, checking their legs for any differences. And I think a lot of that education at the beginning of type 2 diabetes especially, we've already got a lot to say and a lot to do and a lot for the patient to take on board, but it's essential we do that at a very early stage to get them to understand that we have to check. and they have to check, not once a year for us. They have to check all the time.
Yeah, good. What about yourself, Alison? Anything you want to add to that?
I think that is perfect advice from Lynn, and I think we can learn a lot from that, because in such as even, pressure ulcer care or leg care, what Lynn's talking about doing with the diabetes program, checking, we need to get that over more to patients themselves, to be aware of all these, the different signs and symptoms. And it's about that holistic care, isn't it, Lynn? It's not just about the wound. It's prevention of the wound. The prevention of the wound comes from all the the other aspects of healthcare, of having a healthy lifestyle. So
excellent. So question number 4 from Lorna. I've got access to an excellent TVN. However, my greatest problem is compliance and consistency in shared care. Is there any method to ensure compliance? Sorry, I'll either one of you. I mean, is there? If we start with Lynn, because obviously you can talk about it from maybe like a diabetes and things point of view, and then we can talk about it from a wounds point of view with Alison.
I mean, compliance. The patient has got to be bought in to what you're selling. If you want, they've got to be bought into what they want to do, and that you've got that support. So compliance and concordance will only come if the patient is willing for that. And there's many patients that are, and there's also many patients that aren't. So it's just trying to judge that, and eventually perhaps some of those that aren't, you get on board. But it's just a real art and a real skill, really, to get for me to get that concordance and compliance from the patient. So
it's like if I said to you, Alec, right, so so you have to now, I'm going to prescribe for you this compression garment. I'm going to say to you, oh, this is going to be tight and it's going to and all this, but you have to wear it. You're going to go, no, thank you very much. So like Lynn says, it's identifying what the patient goals are initially and what they want, and working backwards from that instead of us being prescriptive. And it's the same with anything we do, like even with pressure equipment, if we're going, just prescribing all like, right, you've got to use that, if somebody's in pain, they're gonna, they're not likely to then accept those types of things. We have to work. It's a real process, isn't it? You've got to gain that trust, and and work from what their goals and objectives are.
Yeah, do you think as well that like if you're going to put somebody on some sort of new treatment plan, whether it's a drug or whether it's a dressing, do you think it would benefit the patient if like, I understand how precious time is, but for a patient point of view, would it be more beneficial if they were able to have more frequent contact, certainly in the initial stages, just to see how they were getting on? And I say that just because I had to phone the doctor this week, and they called me back and I missed the call, and then trying to get back in touch with them, and the receptionist was just like, well, they called you, we've got the record of the call. And I was just like, oh, this is ridiculous, this is. And so realizing that actually you just don't have time, whether you're working in a practice or whether you're working in the community, you don't have time outside of that, outside of the set appointments, either where it's to prescribe something, whether it be a drug or a device, to then actually just be able to just, when we talk about holistic care, just to call Mr. Jones or just to call, Mrs. Evans, both obviously very Welsh names just came to my head there, just to see how they're getting on with it, outside of maybe the 1 week later follow-up or the 2 week later follow-up, just to see how did you get on yesterday with your injection, or how is that compression garment treating you now after 24 hours? Do you need to just make it a bit tighter or a bit looser before the next appointment that we've got? I mean, what are you, and how could we even possibly get around that? So Lynn, I'll throw that to you.
Yeah, I think it's down to you as the professional to make that forward thinking plan. So that's part of your patient plan, to say, okay, we're going to go forward with this treatment. I will contact you Monday, Wednesday and Friday next week. and you carry it on like that until you can let that patient go a little bit further. Because if you want that compliance, they want to know that you're there to support them. And also, I have they can email into the surgeries, and we have quite a bit of this now, that they'll email into the surgery that, could you please get Lynn to call me, and that way you initiate the call, and you're not getting them to ring and sit there for hours and hours. I mean, like you, I tried to ring my GP 2 days ago. I was 10th in line and I hung on for 45 minutes. And I haven't got that time. I've got it on speaker while I'm dealing with other things.
Yeah.
So it's, if we want a patient to succeed, we've got to put ourselves in their shoes and give them a plan. And part of that plan is our contact. And if we're not giving that plan of our contact, we're never going to get this plan to succeed.
Yeah, I agree. What are your thoughts, Al?
I don't think I can elaborate on that anymore. I think Lynn said that very eloquently and absolutely, and I think that covers all aspects of chronic disease management.
Can I just ask another one, another question for myself as well, which possibly is a bit controversial, but where does industry fit in with regard to helping patients be compliant? And what I'm thinking is that if you're putting somebody into something that is going to be a long-term, that they're going to be using long-term, whether it's a diabetes medicine, a very specific type of diabetes medicine, or whether it's a dressing Alison, is there a role potentially, and I'm certainly not advocating passing over responsibility to industry representatives. And when I say representatives, I'm talking about the clinical advisors and things like that. But, they have huge resources. A lot of these companies are huge resources. Is there a role perhaps where at some point in the future the patients deal, once you've prescribed and sort of explained what they should be using, is there ever a point where potentially industry start helping directly with patients in terms of just the use of the products? We're not talking about advocating them promoting their products, but once somebody has been prescribed a device or a dressing, that actually you could utilize the resources of the company that manufacture those to just help the patient.
Yeah, we do that. I mean, I do that anyway, to be fair. I mean, only today, I had an email from a practice nurse about a patient with lymphedema. There's no lymphedema services for them to access. There's no ulceration, but they need particular, garments. So I got in touch with a company who we use from Formulary, who will contact the practice nurse around, measuring and things like that, and guys. And we've done that with patients where, I mean, in my trust, I'm the only tissue viability nurse, so I do look to industry for a lot of our education, not just with nursing staff, but we've also had patients who, some people may think that's very controversial, but we've got a lot of really good clinical ex-nurses or still registers of nurses, advisors. A lot of them are ex-TVNs working in industry, and I think those boundaries have to cross more, and especially now, because in their roles as well, a lot of them, they're not able to come to see me in my practice, but with all the virtual stuff, and we have, why not, let's work together and use a collective knowledge. And where I might be battling resources, or in another TV team, they've been pulled to work, say in the winter, they have to go, their resources are depleted working in ICU, but we've still got patients wanting advice. I think it's something we could work towards much more. Would be a fan. I think we have to be careful with it, and we have to do it ethically. But yeah, I think it could be.
And what about you, Lynn?
I've worked for industry. I've been a clinical nurse advisor within industry, and it does work. However, they're obviously governed by the ABPI, and there's certain things that they can't do to cross over those boundaries, depending on how you're employed with the industry. But the benefit of working for industry and being a healthcare professional and being able to manage patients is really, really good. And none of us would be where we are now without industry, because they have supported all our training, and they continue to do with their sometimes strapped resources now, because they're not as freely available as they used to be. and there's always a lot of skepticism about industry, and I am 100% behind it. Not the skepticism, the industry working, because we need them, because they help us, and certainly within diabetes, there's lots of meters, those sort of things that we need in industry to help with type 1s, the difficult ones. Yeah, part of the shared care, if it's the compliance.
Yeah, of course.
They're
Yeah.
compliant, the ABPI, that's right.
Okay, great. Listen, so we've almost come to the end. I am going to ask one more question, if you don't mind, ladies, just simply because I'm conscious that I've just taken up the last 5 minutes with with just engaging in conversation with you myself. So I'm going to choose question number 5 from John, which is, do you not think we need a whole change of ideas and tactics to treat patients? There is a sense of entitlement around being fixed. Patients need to take more responsibility for their care. What do you think? Crikey, that's a strong one to end on, isn't it? I didn't read the entire question before I got to the end. Lynn, what do you think of that?
I completely agree. We are about chronic disease management in practice, but wounds are chronic disease management, and they've not been seen as chronic disease management. They've been seen as something we need to fit in. But with the complexities and the change, I completely agree. How that model looks, I have no idea. And I wouldn't like to produce that model. But yes, we do. We need, and I do think the primary care networks are changing this model, and the support that we're going to get from the primary care networks will make a big difference. But I also think that we need to audit what we're doing. We need to show what we're doing, and we need to show that there's big gaps.
Yeah, I agree with Lynn, and thanks, John, for that question. But I think we have to change our attitudes. We often take that parental role, don't we? And it's like, and then the patient has always gone, there you are, nurse, there's my leg, there's the wound. And we've always chastised them for messing with the dressing or this, that, and the other and stuff. And so we have to change our historic cultural attitudes towards what patients are able to do, their knowledge. We just assume with things like venous disease, well, they just don't understand, and then they don't comply and things like that. So we have to change our approach. But yeah, absolutely, we have to get that patients on board with autonomy, and like we keep saying, it covers all aspects of care, diet, exercise, all those lifestyle things, and not just from all ages. Let's start with the kids as well. Let's make sure we've got a healthy population, and then hopefully this burden of wound care we'll start to see better results with it.
You'd surely just just for my non-clinical 2 pence worth on that, though, you'd surely think that more people than not actually do have an interest in their own care. I know that from my own point of view, I'm the sort of person that will just try and take care of myself until I absolutely can't, and then I'll go and get help. You'd have thought that, the idea that there's an entitlement around just being fixed without people taking responsibility for, managing their own care, for me is slightly odd. It goes against certainly how I feel. I'd like to have a bit more faith in humanity and believe that, actually people will take care of themselves as much as they possibly can. But maybe I'm wrong, John. These are the 2 clinicians, and it turns out they agree with you. So we'll wrap it up on that note. We've had loads of questions that we haven't been able to get in, that we haven't been able to answer. As I said at the beginning, what we're going to do is we'll make a note of all of these questions, and we'll respond to each and every one of them, and we'll create a document which we'll put onto the website alongside these slides, which you'll be able to download, alongside the link to download your certificate, which should actually be on your screens just now. Alison, thank you very much for another wonderful presentation. There's been lots of lovely, wonderful comments about the job you've done this evening. Exactly the same for you, Lynn. It's been a genuine joy to meet you, and a genuine joy to work with you this evening. I'd just like to thank my team who have been working behind the scenes on the comments and questions, and as always to the whole team over at Mole. But last and absolutely by no means least, a huge thank you to Hartman for supporting this event. And please do keep an eye out, because as I said, they've got a whole new website which they're launching to support shared care. Once that's available and live, we'll be posting links to our social media and sending out emails about it. So do keep an eye out for those. That's it from me. I'd just like to say thank you all for joining us. Thank you all for engaging so much throughout the event. And from myself, Lynn, and Alison, good night.
Good night. Thank you, everybody.
Thank you. Thank you.